Hi, I'm Brian Betts. I'm Vice Chair of Strategic Initiatives here at Roswell Park Comprehensive Cancer Center. Today we're going to be talking about a phase 1 CAR T trial targeting CD83, which is a protein on acute myeloid leukemia. The problem that the CD83 CAR T trial is trying to solve is basically trying to find a CAR T that can differentiate healthy stem cells from diseased leukemia stem cells. CD83 is only present on the leukemia stem cell and absent from healthy hematopoietic or healthy stem cells, which is great. So you can actually target the leukemia, leave the rest of the marrow intact, and reduce the risk for what's called on-target off-tumor toxicity or myeloid aplasia. How do we get to the CD83 CAR? It goes back to when Marco Davila and I were kind of thinking about new CAR Ts that we could use for initially graft versus host disease, which is a complication after allogeneic stem cell transplantation, but also to target leukemias, particularly acute myeloid leukemia. I think the work probably began out in 2018 when both of us were still down in Florida, initially discovering that CD83 is present on alloreactive T cells that cause graft versus host disease. The 83 CAR kind of gives you a little bit of the best of both worlds. It'll go after leukemia, but if we had to use it after a transplant, it also could help with preventing or even treating graft versus host disease. A lot of times when you see CAR T trials, they often exclude patients that have a transplant, and relapse after transplant, that's exactly the patient population we want to target because they're the ones in most need. And that's where CD83 CAR comes in. We have a cell that can focus on leukemia, leave the bone marrow stem cells alone, and avoid on-target off-tumor toxicity. We are New York State's first and only gene and cell therapy hub, which means we have a dedicated GMP facility, we call it GEM, which is run by Dr. Chris Choi. Our GMP facility is the biggest in the country, at least the biggest academic facility in the country, with 20 clean rooms, which means we can generate cells for people on demand and do it in real time, which is pretty exciting. The phase 1 CD3 CAR T trial for acute myeloid leukemia is funded by the 11-day Power Play and also the Alliance here at Roswell Park. To learn more about the clinical conduct of the CD83 phase 1 trial and also about eligibility and more clinical aspects of the study, I'm going to let Dr. Holtan share her expertise on that.
Hello, I'm Shernan Holtan, Chief of Blood and Marrow Transplant at Roswell Park Comprehensive Cancer Center. We know that there is no chemotherapy that will cure relapsed AML. The only potential for long-term cure has to come from the immune system in some way. So currently, the only known cure for most AML is an allogeneic hematopoietic cell transplant. Those who have had a transplant and relapsed would be candidates for this study, but those who are unable to achieve remission can also be eligible for this study as a potential bridge to transplant. But we do hope to learn about the CD83 targeted CAR T cell. This is a phase 1 first-in-human study. The primary endpoint is safety and then finding the optimal dose. So we'll be accruing patients in a manner that allows us to assess safety and make sure that we land on the correct dose that will then be studied in phase 2. We estimate it may be 18 patients and it may take a year and a half to accrue, but that is just my estimate right now. Graft versus host disease is a complication of allotransplant where the donor's immune system attacks the recipient. Historically, this was a big concern in our field. Approximately half of patients going through transplant had this complication. With our current prophylaxis, the risk of life-threatening acute graft versus host disease or moderate to severe chronic graft versus host disease is only in the range of 5 to 10%. What has led to this significant reduction is the use of post-transplant cyclophosphamide after the transplant to eliminate those alloreactive T cells that could contribute to this development. But it's not like the problem has completely gone away. We still have some patients who require long-term immunosuppression. So I envision potentially using the CD83 CAR T cell in the future to prevent graft versus host disease as well. The steps of enrollment on this study are fairly complex, as would be expected with a CAR T therapy. So this is a product that is made from the patient's own immune cells. That means there's going to be some steps, including assessment screening, making sure that someone is eligible, basically free of uncontrolled infections or serious other organ morbidity. Then they'll have to go through an apheresis procedure where their lymphocytes are collected. Those lymphocytes then go off to manufacture, which will take around 3 weeks. There's going to be that gap of time where a patient will need to receive care to make sure that they are stable enough then to go on to receive the CAR T therapy. Administration of the CAR T therapy will follow just similar to current standard of care for other malignancies, with standard lymphodepleting fludarabine and cyclophosphamide chemotherapy, followed by the CAR T infusion and close monitoring for inflammatory complications. I really encourage early referral for this clinical trial and almost any clinical trial, honestly, especially in AML. The chemotherapy that we have is really limited in its efficacy. Basically, if the first line of chemotherapy doesn't work, the chance of second or later line chemotherapy getting us to the place where we want to be is pretty low. Ideally, we'd like to see patients who have had fewer cumulative toxicities from repeated exposure to chemotherapy. So ideally, we would like to have patients referred as early as possible in their disease course to receive this potential therapy.